Thank you so much for that kind introduction. Thank you, organizers, Team Novo, for having me here today. In the next couple of minutes, I'll take you through this topic on MASH and talking about the Essence trial in MASH. Uh, Before I really get started, this is the financial disclosure. But when you talk of diabetes, when you talk of MASH, when you talk of obesity, I think all of them go hand in hand. And it is not only important in terms of just presence or absence of obesity that we talk of MASH. You see that it is presence, duration, as well as severity that makes a difference. I think we all would agree that MASH per se can lead on to increased CVD. We know how obesity leads on to CVD. We see how semaglutide is helpful in the previous talk, but even faster progression to fibrosis. Also talking about cancer, hepatocellular cancer, and mortality. Now, this is really a Western data, 4 in 10, 8 in 10. But when we looked at data from our own clinic, the multidisciplinary obesity clinic that we run in Vellore, we found that 75% of people who walk into our obesity clinic actually have fatty liver disease. So this is something which is really, really big. Many times, just a diagnosis of fatty liver disease is often brushed under the carpet, saying that, okay, a lot of people have it, but that's definitely not the solution. As per all international guidelines, including the most recent ADA guidelines, today it is important and mandatory to screen for fatty liver disease or steatotic hepatic disease in all individuals who have high risk. High risk includes people with diabetes, people with obesity, those who have high triglycerides, but also hypertension, those who have abnormal liver enzymes, liver steatosis. And it's important to screen not only because diabetes causes increased risk of CVD, not only because diabetes and steatotic liver disease is associated with each other, but you also see the left arm of this angle, which is MASLD itself leads on to a twofold higher risk of developing cardiovascular disease. So it is an independent risk factor as well. So like we manage any other chronic disease, be it diabetes and obesity, again, steatotic liver disease require multi-faceted treatment. You have to make sure that your patient's glycemic control is good. You have to reduce the risk of fibrosis and steatohepatitis. Overall weight loss is to be achieved. The CV prevention is also to be achieved. Now, when we look at the current scenario of how we manage this, definitely lifestyle is important, but the quantum of lifestyle required for reduction of steatotic liver disease is huge, to the scale of 15%, which is sometimes difficult with lifestyle alone. We recently reviewed and published this in Endocrine Clinics of North America, looking at all the drugs that are available in the diabetes spectrum, their effect on fatty liver disease. Some showed, some have absolutely no evidence. But the focus of my talk today is on GLP-1 RAs and how they specifically have the evidence, which is really emerging very strongly as to how it can really reduce the steatotic hepatitis load, and specifically we'll be talking about semaglutide. But before I come to the Essence trial, that is the topic for today, let me take you through three small trials, very brief 3 slides that I'll present before coming to the Essence, what evidence we had from the phase 1 and phase 2 trials. Now, Essence trial is a phase 3 trial, and we know before reaching a phase 3 trial, we have to do the phase 1 and phase 2 trials as well. So the phase 1, the first trial, which was done in steatotic liver disease in MASLD with semaglutide, was a 72-week RCT. Now, being a phase 1 study, and I'm sure all of us agree with that, the numbers in these trials are relatively small. Here we had only 67 patients that were randomized. Fairly small study. Again, the major outcome that we're looking at is not something very invasive. When you're starting a new molecule in a new disease, you would like to probably look at non-invasive methods, and the kind of endpoints that you have. The primary endpoint is not liver biopsy. It is essentially looking at elastography, MR elastography, or liver stiffness, which is non-invasive. And that was the primary endpoint. Yes, they were also doing MRI to look at the fat. Otherwise, but the primary endpoint still remained liver stiffness in terms of MR elastography. And you see there was a difference. Though these numbers are really small, when you randomize 60 odd people, you will get very few people who have fibrosis, and then you follow them up for 72 weeks. How many of them progress, how many don't progress, that too through a non-invasive method. This particular study did show the difference. You can see in the slides here that it's 3.7 versus 27, but no statistician would ever be able to get any statistical significance on these small numbers where 1 versus 8 will get you any data. So this trial did suggest a trend, but obviously because of small numbers, there wasn't statistical significance. But yes, the parameters suggested that there was a 50% reduction in the amount of liver fat. So that was the first phase 1 study, and that was good enough to step up to a phase 2 study. So in the phase 2 study, definitely the numbers went up. So previously we had 60 people, now we have 320 people. And here we are looking at the hard endpoint that all of us and all the hepatologists as clinicians want to look at in terms of liver biopsy. But what we notice here as well, that the dose of semaglutide, now what we are going to have for obesity use, hopefully this year, for our own practice here in India, would be 2.4 milligram. But the doses that you see here are very, very low, 0.4, 0.2, and 0.1. Because before, when this trial was designed, that time the 2.4 dosing studies were not done. So we have this particular study where we're looking at hard endpoints, we're looking at larger number of people, but we're looking at a lower dose. And again, the endpoints here is essentially, reduction in fibrosis, reduction in steatohepatitis. And what they found was that there was numerically more number of people with improvement in fibrosis. Now, when we were in medical school, we were always taught that, once fibrosis sets in, it's for life. Steatohepatitis only progresses. But this is the first time we are seeing that with this significant weight loss, it was only with bariatric surgery that has been shown before, but with this particular quantum of weight loss, we do show improvement in fibrosis, do show improvement in MASH in terms of MASH resolution, which is indeed a big landmark. But again, because probably of the smaller dose, this was not significant. So we move on to the next phase 2 study. Again, in this particular study, the numbers are only 71, but this is the first time 2.4 milligram dose was used in people with steatohepatitis. And again, here they are looking at liver histology as well as an important endpoint, and the primary objective here being, reduction in one stage of liver fibrosis. So we have less number. Obviously, when you do liver biopsies, it's hard to get large number of patients, but with 2.4 mg. But the other point that I'd really like to highlight in this study is that when they recruited these patients, they for some reason chose that these patients should have a very high stage of fibrosis stage 4, which is like cirrhosis. From our knowledge in dividing fibrosis, we know stage 1, 2, 3, 4. 1 is no fibrosis, 2, 3, 4 is mild, moderate, severe, and stage 4 is near cirrhosis or cirrhosis. Now, in patients with cirrhosis, they're trying 2.4 milligrams in 71 patients, good RCT, follow up for 48 weeks with histological endpoint. And again, phase 1 and phase 2 trials predominantly have the aim to look at safety. And yes, this was safe and well tolerated. They did not meet the primary endpoint, but overall, it did show improvement in the liver fat content, improvement in steatosis. But these 3 studies set the stage for the ASCEND study, which is a phase 3 study, and which takes care of all the drawbacks that I've mentioned in the previous study. The sample size in the ASCEND study is good. The dose of semaglutide is 2.4 mg, and not end-stage liver disease. Stage 2 and stage 3 liver disease have been included in this study. Good duration, large number of patients, 1,200 subjects. So that's a really big trial for fatty liver disease, where you're looking at liver biopsies across the globe, 1,200 patients with a full dose of semaglutide for a period of 5 years. But right now, what I'm going to present to you is only the part 1 data, which is about 72 weeks. But then part 2 data would be at the end of 5 years, which is not yet published. This was also presented recently at the US Liver Society meeting. The primary objective here is essentially very hard endpoints, resolution of steatohepatitis, and improvement in fibrosis at week 72. India was a part of this study. There were about 30 patients recruited from India. And the easy way to remember the results of this study is just a rule of 60 and a rule of 30. What this study showed, that 60% of patients who received the drug had resolution of MASH. Now that's a very hard endpoint. resolving steatohepatitis is something that we've not really seen so much in literature. This is the first time a drug used in so many people across the globe shows data that 62.9% of people had resolution in MASH. Not only that, they had improvement in liver fibrosis, the rule of 60 and 30. So 60% had resolution in MASH with no change or worsening of fibrosis, and 30% had improvement in liver fibrosis. So this is something which is really big. When we combine both two, that is having resolution of MASH and improvement of liver fibrosis, the 60-30 rule, 30% of these patients. So if we prescribe this drug in people with MASH, 2 out of 3 of my patients will not have MASH anymore, and 1 out of 3 would have fibrosis which is resolved, fibrosis which is improved. And 1/3 of the total would have both the outcomes achieved. So definitely very hard outcomes. This is data at 72 weeks. We are still looking forward to get data at 5 years. Let's look at some other data from this study, looking at the SF36. SF36 is quality of life. Again, that was improved using semaglutide. The quantum of weight loss in these patients with MASH, 10 kgs, definitely that's something significant. Overall, looking at cholesterol, triglycerides, HDL, hsCRP, everything seems to improve. Even the non-invasive markers are speaking the same language. So 10 kgs weight loss and 1% reduction in A1C as well, even though non-diabetic. So the easy way of remembering the results of the ASCEND study is the 30-60 rule. 30% have improvement in fibrosis, 60% have resolution of MASH. And all the other small parameters, the non-invasive parameters that we use in our day-to-day practice, triglycerides, HDL, total cholesterol, blood pressure, hsCRP, everything seems to improve. But the bigger question, the side effects. So again, there's data with that. When we look at Wegovy in terms of SAE as compared to placebo, exactly the same, 12 to 13%. So it's not that using this drug is going to cause more side effects. Definitely there would be GI side effects, but we've been doing semaglutide trials for over a couple of years now. And patients, when they start tolerating, initially, yes, there is a curve, but thereafter they do pretty well. And you see the side effect profile is not very different. What is the mechanism of improving fatty liver with GLP-1 specifically semaglutide? Excuse me, but the main thing I think is still the weight loss, because we said 10 kg weight loss with this drug. In step 1 trial, we've seen data for 15 kg weight loss, and that helps. But overall, reduction in inflammation. Several studies have shown reduction in inflammatory markers using this GLP-1 and therefore that also has an impact on improving the fatty liver, also improving the metabolic effects. And all this data that is summarized here is data not from animal studies, but from human studies. So in summary, what I would really like to say, the key learning points from the ASCEND study that we are talking today about of using injectable semaglutide in the dose of 2.4 milligrams once a week, we see there is improvement in steatohepatitis. 60% have resolution of steatohepatitis, 30% have improvement in fibrosis. There is reduction of weight, there is reduction of A1C, but there is reduction of all these other markers, the non-invasive markers like hsCRP, the LDL, the triglycerides, the glucose, all of that improves as well. The side effect profile, very similar to the placebo. Before I close, I thought I'll just show a very recent paper. This is published last week from our center. Fatty liver disease problem is definitely big in our clinical practice, and there are very easy ways to identify it as long as we look for it. And now with the upcoming treatments that are so effective in treating, I think all of us as physicians should definitely not miss out this diagnosis in clinical practice. I'll stop here, but would be happy to take any questions.